then how that data. So a lot of exploitation that happens because those countries that don't have resources, or those institutions, individuals, families that don't have resources have no say. Decisions are made on their behalf. Now, for human resources for health, the issue is about numbers of the health workforce. It is about education. It's about curriculum that is not locally developed. Many books that we use, literature that we use that was not even originated from our countries. Somewhere, somehow, somebody writes a book on midwifery, it comes to Malawi with pictures of babies that don't even look like African. So, I mean, all these issues are about colonization. So whether we like it or not, we are still colonized. And I think the issue of recruitment, retention, these issues are real. We still cannot claim anything. And of course, limited local expertise in many, many areas. So for me, I want to give an example of even just development of vaccines. And I've cried, like, can Malawi come up with a vaccine? Can we have partners that are willing to say, okay, we'll develop this vaccine, but we can do it in Malawi? There will always be reasons why that can't happen. But the reality of the matter is, if there was local expertise, Malawi should have had its own vaccine, because it's happened, other countries have it. Now, so the question is, why are we not developing expertise in all countries so that we don't have to be rushing? There was a time in Malawi where people wanted to get the jab and there's no vaccine, and people are crying and people are getting unwell and then people are dying. I think the fairness that people may say, no, we are fair, cannot be justified. Inequalities that are real, inequalities that cannot be explained. And of course, the issue of skills gap, quality versus quantity. So at the moment, there's always a push to have as many health workers in countries, but we know that many times students are not going through proper education, lack of equipment, lack of teachers, lack of laboratory, lack of infrastructure. And there's also this mismatch where perhaps organizations, those with resources, would be saying, okay, we'll support, but not everything. We can only support infrastructure or partial infrastructure or software, scholarships. And I have just gone through a process of a certain funding process where I did ask the question, I want infrastructure, I want a girls' hostel. And I was told, no, for this funding, we can only provide scholarships. So at the end of the day, no one is making decisions on the other side. It is actually those who have resources that are making decisions. And I want to say this, that for me, the 3 decades I've worked, that story seems to be the same. And I don't think that people are really serious when they're saying they want to see things change. I like this slide because this slide talks about the percentage of global burden of disease. So like, as many people that are getting sick, we need as many health workers. But when you look at this slide, you see that, not now, of course, Africa used to have quite a high disease burden. And yet, when you look at the global health workforce, we were the lowest. I am saying we were, because I don't know what has happened with COVID, whether this is true the same, and I think I'm trying to tease data to see what's happening. But certainly the opposite is happening. Where you have so many health workers, the disease burden is also as low. Let's take out COVID-19. But I think with COVID-19, probably this picture may be changing a bit. We cannot make a difference in people's lives if we don't have health workers that are well-trained, that are well-remunerated, that are happy to do what they're doing. The more they are frustrated, the more they leave the healthcare system. And this challenge is something that we all need to be worried about if we truly are committed to global health. So the slides are not moving. Maybe I can have, okay, that's fine. So also this atlas is something that I want you to all appreciate, looking at countries with critical shortage. When I checked on WHO website, I thought this has changed, but it seems to be the same. So when you look at Africa, basically critical shortage, and yet you see the disease burden is very high. And then the other countries in pink, without critical shortage, but I'm sure with COVID-19, probably the story has changed. What we all need to always be mindful about is the fact that where you have enough health workers, maternal survival, child survival, infant survival will be much, much better. Low. If you don't have health workers, then you lose more children, you lose more mothers, you lose everybody. I think bottom line of what we're discussing. So if we are reimagining global health, we are talking about survival. And survival is about basically maternal, newborn, and of course, all other diseases. So I know now we're talking about both communicable and non-communicable diseases, but basically for our countries, mothers and children suffer most. And I think this is something that we all need to be worried about. Now, going into politics. So I want to talk about politics. So politics about who leads in a country is one element. But I believe that if we are going to make a difference in global health, there has to be transformative leadership. So leadership that is able to make decisive decisions. Leadership that can ask relevant questions, that leadership that will look at sustainable development goals when they are at the UN and ask relevant questions. Leadership that can also question decisions that are made at regional level. So in Africa, we have the AU, we have SADC. We need to start questioning because there are resources that support all these institutions, but also in our own countries, leadership that can actually question every system that doesn't seem to be supporting the common man, that rural man, that woman who has no voice, who will never go to a city, who will be in a rural area and who is suffering. I also want to say that when talking about global health, we should always be looking at environment. Is the environment conducive? And I know many times that people don't really think about these issues, but they are critical. They are very important. And of course, national politics, because many decisions that have gone wrong in many countries. So initially, people used to think that actually national politics are an issue for only low and medium income countries. I think what we've seen over the past few years is that even high income countries have got political issues. But we should know at the end of the day that these country issues, national issues do affect a common man, because in each country, so global health, many times we're only thinking, okay, it's low and medium income countries, individuals in those countries, but we also know that also in high income countries, there are individuals that don't get that quality care and that need support. And national politics actually influences what happens. Regional politics, also another issue here. International politics, another issue here. And you know, these conversations we should be taking forward, but at the same time, we should start asking questions and not to fear that if I ask this question, then perhaps my country will suffer. I think many of us should now start saying, even at the UN, put up your hand and say, this is not right. Vaccines should be available everywhere in the world. Now, the moment we start getting to those high tables and start making those contributions and questioning, well, maybe people may not listen, but I think somewhere, somehow, somebody is going to listen. So therefore, politics should never, never be ignored. And I also want to repeat, politics is not just about low-income countries. We've seen high-income countries have also got their own political issues. And of course, climate change. Climate change affects everything. And I put it under politics because many of the issues that have gone wrong are about leaders that don't make right decisions, are about leaders who don't care if people are cutting trees, are about leaders that don't care what's happening in industrialization in their country. So this issue is very closely related to politics, and it is politics that's influencing global health. And if we're going to really re-image global health, we have to start looking at these issues with another eye and saying, how can we strategize so that we make the world better? Now, issues of technology. I want to address this issue now because digital divide has become so prominent now with COVID-19. And I do believe that if we're going to address issues of technology in global health, then there's need to look at legislation and policies. Policies at national level, at regional level, and also global level that may put pressure on those that have got resources, but also put pressure on those who don't have resources on how they move forward, on how we move forward. And I want to give an example like on policies. So in a country like Malawi, we have telephone companies that make a lot of money. Isn't it high time that we put pressure on them to say, look, for you to do your business in Malawi, you have to put a certain percentage of your resources into primary education or certain resources into healthcare system in Malawi. Because unless we create these policies that will push for the poor man, people will still be getting rich even in very rich countries. But at the same time, the reason why I'm saying that legislation as well is because decisions of this nature, you cannot influence a policy if you have a very weak legislation. And therefore it means politicians who make those decisions in parliament must be willing to speak for the poor, to speak for those people that don't have a voice on their table. Local capacity building. There's a tendency, even in global health, that we all claim, okay, global health, but we are not building local capacity. We still want to be on the ground. We can't even trust those that are on the ground. I think it's high time that we really empower people within countries to do the work, and we only support them. Otherwise, if we don't build local capacity, what will happen is if you are funding for an activity, you go into a country, you go into a community for 3 years. Yes, there will be progress during that time, but once you have gone, no sustainability. So local capacity building is very important for sustainability. And also appreciating indigenous knowledge. So at our university, we have actually a whole school of indigenous culture and heritage, because we realize that we are a people. We have our culture, we have beliefs, we have practices that can add value. We can even come up with innovations, technology, using our indigenous knowledge. Let's not ignore indigenous knowledge. We can achieve so much in global health if we allow countries to use their indigenous knowledge, give them space and support them. At the same time, also accept differences and issues of scaling up. So scaling up, very important, because we shouldn't be looking at small issues and we leave, perhaps we come into a country, we do something small with 10 people, 20 people, and then there's no potential for scaling up. So all innovations, all initiatives on global health are so small that they can't even be scaled up. No difference at all. When everything is said and done, no legacy left. Scaling up is critical for global health. And of course, funding. And funding, I think funding is something that we all know. Funding is a critical matter. When we are saying funding, we're not talking about funding where on paper, this money, $10 million, 10 million pounds is going into Malawi, but half of that money is going to technical people that flying into Malawi. I'm talking about funding that will be in that rural community and make a difference to the people in that community. Now I want to say this, that for collaboration, which is critical too for imaging global health, there should always be a win-win situation, a win-win outcome. so that we don't say we are collaborating, but at the end of the day, 80% of what we brought into that country goes back to the high-income country. Win-win. And if you're coming to collect data, the impact of that research should stay in that country, not taking out all the papers. And at the end of the day, it's just history. And for me in Malawi, I've seen many projects over the years, 30 years that came into Malawi. People come into Malawi, they do this project, no sustainability, they leave, now it's on a history and papers that somebody published somewhere. No. But also we should know, Nelson Mandela once said, if you want to go far, you need to go with others. You want to go fast, go alone. And we've also seen in global health, institutions, programs that are going alone. So they come into the country through their government, through their embassy, and they rush in and go. You want to make a difference in Zambia, you want to make a difference in Malawi, work with Malawians. Let's hold hands together. Multi-sectoral approach. That's what is going to make a difference in people's lives. So my reflections, and I'll be finishing shortly. I have always believed that there should be leadership. And I've always said you need to be on the table. I was talking earlier on in another panel and I said, look, let's invite ourselves on the table. So I do believe that if we're going to make a difference in global health, if indeed there's going to be reimaging, allow those that you think you are helping be on the table. Because you're not necessarily helping. We are not necessarily helping anybody. We are building skills, we're building capacity, but let's allow those that know the local expertise tell the stories. They should be on that table. And when they are on that table, they should choose the menu. Don't choose the menu for them. Local expertise is always very important. Allow people to tell their stories. Don't tell stories about people, Malawi, tell stories about, China, tell stories about India. Allow people in those countries to tell their stories. It's very important because the reason why there has been a struggle on decolonization of global health is because somebody is telling that story. But I do think that let's allow people to tell their stories. And even for us in our countries where we have challenges, when we go out in rural communities, allow people in the communities to tell their story and to tell us what they think should be done and allow them to be participants, should be there, even leading sometimes. So if we're going to do, if we have perhaps funding, and a good example, because we're universities, so UCSF has got funding, they want to do work in countries, and I'm going to give a good example of a study we're doing on family planning with some of the colleagues at UCSF. I love the approach because there's been co-creation. We've been together all the way. We're planning together. Our initiatives, our phases of each level of the study have been done together as a team. Each candidate represented on that project make decisions, and we are leading in our country. So UCSF is not at Mast, is not in Uganda, is not in Nigeria doing the work. It is people in those countries doing the work. I have no doubt that at the end of the work we're doing, there will be sustainability, and that's what we need to see. And I'm also talking about language beyond English. So what I've seen that in global health is that because everything seems to be English-based, everybody wants to understand each other in their own language, we lose a lot. So there are languages in those countries that we should allow people to use their own languages and describe what they want to do, to even co-create in their own context. This is beyond, I think, the meaning English. It's about allowing people to do things in their own context because they understand very well what can make a difference. And of course, I think something I mentioned earlier on, critical review of legislation and policies at national, regional, and international levels. In other words, let's allow for autonomy. Another issue for reflection is, I think we still need to collaborate, yes, and I said earlier on, a win-win situation, we need to rethink our partnership. So what I've just shared earlier on is, in the past, people have always believed that there's no capacity in such as a country. And more importantly, I think LMIS is a victim. So low income countries, medium income countries, there's no capacity there. We'll go in, we'll do this, we'll do that. I think we need to stop thinking like that because there's so much capacity there. All we need to do is support individuals, support institutions so that they can do the work instead of us going in and creating solutions. Activism and lobbying for support is very important with local agenda. I think we need to build civil society, non-government organizations. And I want to emphasize civil society because I think civil society in many of these countries have really been about politics. But I think there's so much in global health that can actually be pushed by civil society. But for them to do it well, they need capacity building. Let's get them on board. Let's not leave anyone behind. We need to get everybody on the table and then we push the agenda together. But also very important is about mentorship. So Kim and myself are very good friends. I don't know who mentors who, but I think mentorship can be done at peer level, can be done at, of course, at different levels. So I have so many people that I mentor. There are also many people that mentor me, but it's very important that we build mentorship at all levels, whether it's research, clinical practice, everywhere, because at the end of the day, we are building capacity for each country. And as I said, as I finish, perhaps just looking at a few issues here, making sure that we all know that there are emerging issues. The new dimension of politics, as I said earlier on, countries that seem to have known democracy very well don't seem to be doing very well. So we need to take control, take cognizance of the fact that it doesn't matter where you are in the world, anything can happen with politics. So very important for global health. Equity and access, very important. Changes in disease burden, this has humbled high-income countries. I think COVID-19 has exposed weaknesses, I think, for every level of economy. Research deficiencies, so vaccines, I talked about this area on. And of course, exposure of inequalities, digital divide, I talked about this area on. And of course, the role of global health during COVID-19, very obscure. Because I don't think that there's really much we can say we have done in our thinking as people that love global health. What can we show? I think very little, because I think there's been so much limitation. And I really want all of us to reflect on what can we show in 10 years, 30 years time, what can those of us who believe in global health say we have done? Because I think there's been so much limitation. And then, of course, finally, what's the roadmap? So what's the take-home message for me is let's rethink our strategies. Talking, yes, we can have meetings, conferences, webinars, but I think we need to step back and see how can we make a difference? And then better coordination. So better coordination, I think co-creation I gave as an example, I think is a better way of coordinating. And I would want to encourage that, as I said, really applauding USSF, because I think I've seen you really are working very well with partners, but also other institutions represented here. I think we need to have one voice, speak one voice, and then, of course, do things different, as I said, rethinking our strategies. We can't do the same things. The last 10 years, everybody's saying the same thing. Actually, maybe some of you would not even pick anything from me because we're talking the same things. What I'm saying is, can we reflect and start thinking differently? And then if in terms of coordination, cooperation, can we do this better than claiming on paper we are coordinating, we are cooperating, but what happens at the end of the day is we're still leading in those communities, leading in those countries, because we think the people in those countries and those communities don't have capacity, they can't do things. And then finally, investment. So investment here is at national level. Countries, our own countries should actually start investing much more. rather than depending on donors, because donors with COVID-19 are also struggling. So is there a way in which even private sector in our countries can start taking steps? Can they support innovation? Can they support education, support healthcare systems? We've seen a change, a lot of donations in hospitals, oxygen machines and everything happening so quickly. I think it is an example that it's possible to actually create resources within countries, even that don't have all the resources in the world. So let's invest, private sector investment, but also government investment. And of course, for those that don't have resources, to really release resources, but don't tie the resources, so that, you know, for us, for you to do this, we need to do this. For you to do this, you need to do this. No, that's not support. That's not sustainable. And of course, accountability is something, when you're talking about investment, you can never ignore accountability. So those countries, those institutions that get support need to be accountable. We cannot be talking about corruption, and yet we know there's so many people that are suffering. Let's invest, but there should also be accountability. So for me, what I see are things that we need to be looking at, reflecting on, moving forward. If we're going to reimagine global health, we need to address these issues. Very, very important for all of us. So thank you very much for your attention. I do know that I've taken a little bit more time, but if there are any questions now, comments, I will now hand over to the convener. Thank you very much.
And thank you so much, Professor Malata. That was incredibly a wonderful talk, and we're really excited to get into the Q&A portion. So just a reminder for everybody on the line, please feel free to drop your questions in the chat, or if you'd like to ask your question, raise your hand and we'll try to bring your questions into our discussion. There are some questions already coming in, and so I wanted to get started with a few that I'm seeing. And one is just that a lot of the attention to the question of decolonizing global health has really been coming from institutions in the global north. And at the same time, you spoke incredibly clearly about the need and the importance for local knowledge, locally developed curriculum and leadership. And of course, we heard about your own role as an educator and mentor. So I'm curious if you could talk a little bit about the role of institutions like your own in decolonizing global health, and how institutions like ours can be true partners in dismantling these colonial legacies.
Yeah, so that's a very interesting question, Naomi. I really like it because at the end of the day, yes, it's been global north, but I think we should start asking the question why. Because I think everybody's comfortable, but I think we shouldn't feel comfortable that the status quo is in this manner. So global south, what is it that we can do, we ourselves, to start, claiming the ground? So for me, it's also the ball has to come to us to say, what is it that we can do? So I do believe that what global north colleagues should do is start letting go. And I think I gave an example of what we're doing with some of your colleagues at UCSF, is let go. Give people confidence that allow them to do things, allow them to create what they want to do. And I want to give another good example, I think, is Norway. I remember a grant that we managed a few years ago where all the resources actually came to Malawi, and we're the ones in our institution at the College of Nursing buying tickets for colleagues. It's as simple as that. A ticket for you to come to Malawi has to be bought in Malawi. But the moment you say, no, the ticket has to be bought in the US, it means you think it might not be done well. So these little things matter. So for me, let's start with the small things. Let go. and trust that people can do it on the other side. But I think for those of us then in the global south, we should do is start showing that we can do it. Confidence, accountability, and making just the right decisions at the right time. And I think the moment we're not responsive, then people start worrying whether things are going right. So it's really, I think, both sides letting go, but both sides trusting each other. So the issue of trust is very important. And then, of course, acceptance of local knowledge. So a face mask, a face shield that's been created at MUST should be promoted by even international partners and even, export. Because the moment you're exporting products that are made by an institution of higher learning like mine, it means you are saying it's okay, it's of good quality. So at the same time, we should also ensure that there's quality in whatever we do so that people don't doubt our efforts. So indigenous knowledge, yes, but there should be quality, there should be safety, but also on the other side, colleagues in the global north should let go. Because many times they want to let go on paper, but in action, no. They still think it can't be done there, it has to be done here. And those foundations, even sometimes that are giving resources, they put no limits, this can't go this way, because the moment you start doing that, then you are not trusting those on the other side of the world. And that's also within countries too. I'm not just talking about perhaps the US, Malawi, or Norway, Malawi. I'm talking about even Malawi, Lilongwe City, and Malawi, rural Mulanje. I think that should be the case.
Yeah, that process of letting go is a challenging one and a really good reminder. We've been talking a lot about how do we turn all of our conversation about decolonizing global health into actual action towards that goal. There's a question from Kwame Asamoah. Would you like to ask your question, Kwame?
Okay, thank you. Professor Malata, thank you for that thought-provoking talk. But one question I had, among a lot of things that you said that one can ask a question about, is on the indigenous knowledge. And I normally say that most of the problems we have in health sector, they come also from their local problems that will be better solved with local solutions. However, even within our countries, you realize that most of the elite or the educated frown upon the indigenous knowledge, which are mostly culturally sensitive and applicable. How would you promote the acceptance within our own country that the elite will embrace and use the indigenous knowledge which are culturally appropriate? Thank you.
Thank you very much, Kwame. That's a very good question. And to me, I think what we've done at our university, the mere fact that we have created this whole school and are offering programs and programs that are practical, even trying medicines now, traditional medicines, and we've planted even, some of the trees on campus. We want to give confidence even to Malawians to say, look, we are a university, yes, an institution of higher learning, we're doing research, this is okay. Because the moment we leave it to the people in the rural areas to manage, then therefore there always be issues of quality, of safety. But if it's done on the university ground, then there's no reason why people within countries should be doubting. I think what has happened over the years is that some people have always felt, okay, leave these things to traditional people, traditional healers, give them limitations, give them policies. But I think it's high time institutions of higher learning embraced indigenous knowledge and practices and then do it on campus. And then you can have an interface with traditional people, but at the same time, you're also mindful about the science. You can actually check whether this really fits into what you're doing as an institution of higher learning. But I personally believe that just really doing this on campus gives a lot of confidence. We do have a long way to go, but I have seen with COVID-19 that some of the innovations and some of the practices that we have been using are all indigenous. And they've made a difference. So I think it's very important that we allow universities to claim the space and work with the people on the ground. I think rather than saying it should be done in the rural areas, because I think that's been the case. So everybody's always suspicious. Is this good enough? Is this witchcraft? I remember when we first opened our school, we had to go on radio, TV, saying that this is not about witchcraft, because everybody thought, this program, is it about witchcraft? It's not about witchcraft. It's about indigenous knowledge. It's about practices that can make a difference. And we've seen what's happened. And actually, our own head of state was interested to see some of the activities that are happening in that school, because they have made a difference even in the healthcare system. Thank you. But I also want to hear your input on this in case you have other comments. Thank you.
Yeah, Prof. My small concern over there is the taking away from the community to bring it to the university, and always it will be in the university with the airline. Whereas most of these indigenous knowledge are traditional culture that generates from the community. So how would you address it so that the community will not see it as something coming from the elite group in the university, but it is for all of them, so that they will also, the solution that comes out of the university's research will be embraced by them, because they see it as part of their knowledge.
Yes, so the very reason why we have decided to take this on board in the universities is because the other way you've described has not worked. There's a lot of suspicion. But the moment you open the university, so the university corridors are not only for the land. We believe as ourselves that there should be space even for those that haven't gone to university. So in other words, what I'm trying to say in my explanation is that they can actually even come on campus, because you need to give confidence to people. Everybody has demonized everything that's traditional. But if somebody from the village is able to come on campus and actually teach even people on campus to say, this is how this particular plant works, then there's going to be trust. So the model we've taken is because we've seen the very model of living everything in the rural area, in the community, has not worked. So the one way we think we can actually make a change is to allow those people to come. So when I say the university is doing indigenous research, it doesn't mean that we're doing on our own. Actually, we've had traditional people come on campus and camp with us and give us some ideas of what can make a difference. So it's a model, it's a new model, but we do think that it's going to make a difference. And I also want to give another example of bringing people from the rural areas to come on campus and bring innovations. At the moment, we've got a community initiative. Those people that didn't even go to secondary school, but you look at their innovations and they have space on campus. So what we are saying is when they come on campus, then we can go back with them to the rural area, to the village, because then the people in the village, they will know, okay, I think we are working as partners, because you have to build trust. At the end of the day, if there's no trust, you really can't make a difference. But I do think that particularly here in Africa, we have a long way to go, but I think let's start making those strides that can make a difference in global health. Thank you.
Thank you. And I think we have time for one more question. So Kala, Meta, would you like to ask yours to close us out?
Yes, absolutely. This is Kala Mehta, Associate Professor in the Department of Epidemiology and Biostats at UCSF. Really nice presentation. I understood what you said about traditional healing and also about letting go. But what do you think, Professor Malata, is the first step for us faculty in the US? What is the first step you would advise us to do?
So I think for first step for colleagues there is start thinking sustainable. Because I think whatever initiatives, if you start by thinking that is this sustainable, many of the decisions that are made will be made differently. If it's not about sustainability, then people jump into Malawi, jump into Zambia, Uganda, and then they bring in their initiatives, they do research, bring few people on board, they leave the country. Not sustainable. Now, everyone who has passion for global health should always think about when everything has been done and we leave this country, what difference would we have made in that country? So the moment you start really thinking sustainable, many things will be done differently. So the need for co-creation, the need for co-funding, the need for you to build capacity will be very, very paramount. And you also start building trust. You look at some individuals, you believe in them, you want to mentor them. You'll be thinking about 30 years from now, what will happen? As a leader in my university, as Vice Chancellor, I'm always challenging my staff and saying, don't think about today, think about 30 years from now. What will people say about this program? What will people say about this initiative? What impact would we have made on people's lives? So the moment you think sustainable, it will change. So my challenge, my message to all of us listening today, even myself, is let's think sustainability. Sustainability that can make a difference in people's lives. Thank you.
Thank you so much. And Mike, do you want to close us out?
Only by echoing, our gratitude of Naomi and the rest of the audience, Prof. Malata, for your insights today. Thank you so much for joining us at this late hour in Malawi. Great to have you with us and sharing your perspective. Thank you so much.
Thank you very much, Mike, and thank you very much to all our listeners. Thank you. Really appreciate.
Thank you. And for those that didn't see in the chat, we have another conversation, Reimagining Global Health, on September 23rd with Shay Abimola from the University of Sydney, who again is a leading thinker in this space, and we're grateful to have him join us. So please participate if you can, September 23rd. Again, thank you, Prof. Malata, for your time. Lovely to have you with us today. Take care. Thanks, everybody.